All right, beautiful. Can everyone see my slides and hear me?
Yep, I can.
Wonderful. Um, Hello, everyone. I took a quick photo to share it with my mom as she has been working as a pediatric ID nurse for 35 years, and it's something that will make her as happy as I am. As a little background about me, my name is Gabriel. I work as a transplanted oncology ID pharmacist in the southeastern part of the European Union in Romania. And today I want to briefly share with you something that has made me jump out of bed with excitement for the last 3 years since I've started my stewardship journey. So even the title for today's presentation is about sharing the journey towards starting the first antimicrobial stewardship program in my country. For my perspective, I have a different definition for stewardship. Stewardship for me is about protecting resources for future generations, and I have fun in the process of doing it. So even if I've been doing it pro bono for the last 3 years with what there is available here in Romania, this is because it's my way of giving back to the community and the patients. And I'm so thankful to be here and humbled to be a part of this amazing group. I've learned a lot during the monthly antimicrobial sessions, and it's been wonderful. Talking about giving back and gratitude, I want to show you and answer the question, how did I hear about WVCTSI Project ECHO? Well, everything started back in January 2024, as you can see, when Dr. Mike Stevens posted on Twitter and an announcement related to a lecture series from West Virginia University Med School on antimicrobial stewardship, OPAT and COPAT. I was going back on the platform and I was looking on to find the post. And the reason why the health outcomes for my patients have improved and why becoming an antimicrobial steward has become the biggest priority I have. And I found the original post. This is it. And the reason I made the Twitter account in the first place was the ID Twitter community. That is a huge source of knowledge and education. Then scrolling down, I came across Dr. Stevens's post, and I was right. Looking back, scanning the QR code was one of the best decisions I've ever made, and I am forever grateful to be a member of the project ECHO's family. So why stewardship? Is there a rabbit hole that goes somewhere, as in Alice in Wonderland's first chapter? Well, at the end of the rabbit hole is data, and this is the data my country has submitted to the European CDC. As you can put filters on their website. You can choose what type of information you want to see throughout the surveillance atlas. And here I have screenshotted the three biggest issues from a resistance perspective. As we can see, more than 50% of Klebsiella and Pseudomonas isolates are resistant to carbapenems or a combination of a carbapenem and a beta-lactamase inhibitor. And in this case, we can assume, based on what we see in clinical practice, that a high percentage of isolates are MBL producers. And at the bottom, we can see that almost 90% of Acinetobacter isolates that we have reported back in 2023 were resistant to carbapenems. Our Ministry of Health would argue that these high numbers are because Astronium has not been yet approved in Romania, so we cannot test the combination with ceftazidime avibactam for susceptibility, and then use the combination to treat these infections. And in fact, this was the official explanation that was given in an interview by him. But the main issue here is actually a lack of stewardship framework and not having an antibiotic committee, for example, or ID personnel in every hospital responsible for preventing scenarios like this by implementing the CDC's 7 core elements of antimicrobial stewardship. I believe that the first step in solving any problem is to recognize that there is one in the first place. And I want to briefly describe how we started way back in 2023 during my last year of residency. In January 2023, we had 28 cases in that month of C. diff because of the misuse or overuse or a combination of both, but I think it's overuse of cephalosporins. It was around the time where C. diff was becoming a huge country priority at a governmental level and also the patient level. So it was really good timing, and I think that that was imperative, the urgency or political dimension sometimes to get the program going, because without that, it could be really challenging. But in January 2023, that was the most C. diff cases we've ever had, in fact, either before or since, and we had to do something about that. The hospital I was working during my residency had a very rudimental stewardship framework at that time, and we didn't have any basic framework for stewardship, such as guidelines that are easily accessible, nor any CDC's core elements in place. So the first thing we did was to create a local antibiotic committee in the oncology department, having one of its first role to debunking myths, such as my patients are sicker, or my patients are different, or because they have low counts, they require antimicrobials with a broader spectrum of activity for more days until they reach a certain threshold for counts. And usually the patients need combination of therapy because, 2 is good, but 3 is better. And the 3 antimicrobials should all be administered intravenously, because having an immunosuppressive state following chemo makes our patients fall in the category of severe or complicated, and it's not necessarily true. And we are really fortunate. I have to give a lot of credit to one of the foundation's co-founders, because she was really engaged in this area, and she completed a master in global child health at St. Jude Children's Research Hospital in Memphis, Tennessee, having one of the goals to generate evidence-based research and enhance practices around infection prevention and control, antimicrobial stewardship, and OPAT. In retrospect, at that time, in January 2023, she was the only one that believed in my vision towards having the initiative to implement the first antimicrobial stewardship program in our country and build a lifelong career around it, because this is what I love doing. So in a more positive light, I think this is a pivotal time for antimicrobial stewardship pharmacists, and we have a good opportunity to kind of reimagine the future of stewardship and refocus. I've mentioned here on this slide, so this was published in the Joint Commission Journal on Quality and Patient Safety a couple of months ago, where they conducted interviews with antimicrobial stewardship program leaders in 46 Joint Commission accredited hospitals across the United States, with the purpose of finding what are the 5 super facilitators to implementing stewardship practices. 5 important and mandatory characteristics a hospital must have in order to receive the Joint Commission accreditation, and furthermore, the Center of Excellence designation by the IDSA. And when we started back in 2023, we had only one of these 5. And the 5 essential items in every stewardship department's pocket are an optimal electronic health record, dedicated staffing, ID expertise, leadership commitment, and physician champions that enhanced buy-in from clinicians. On the next slides, I want to present the challenges to stewardship in immunocompromised patients. And the primary one is that immunosuppression is an exclusion criteria for most of the RCTs. However, data is limited, but it does exist, and the data around this patient population increased the stewardship interventions that have been associated with guideline concordant management, increased rate of IV to PO, conversion, and decreased duration of therapy. We often ask ourselves on words, is shorter better in high-risk neutropenia and solid organ transplant recipients? And the answer is yes. Several observational studies were published with varying approaches related to the populations that were included, timing of the escalation, discontinuation versus step down to prophylaxis, and so on and so forth. So these here are all observational studies assessing a short, defined as less than 10 days of therapy for bloodstream infections in neutropenic patients. The second table, so I've listed here, this is a retrospective cohort study from Henry Ford Hospital that was published in August, where they evaluated short versus long course antibiotics for uncomplicated infections in ambulatory solid tumor patients. And what they found was that among 303 patients, outcomes including infection recurrence, treatment delays, and adverse events were similar between groups, suggesting safety and effectiveness of short course therapy in select immunocompromised patients with potential benefits including reduced resistance and adverse events. Some will argue that the caveat here is that the drug of choice matters. And I would say that the drug of choice needs to be optimized to PK/PD perspective for the patient. There are also two RCTs published on early discontinuation on antibiotics in febrile neutropenia, and this is the backbone of my daily practice, especially the first one, also known as How Long study, published back in 2017 in Spain. It is an open-label randomized control phase 4 trial where they randomized adults with hematologic malignancy or undergoing bone marrow transplant and febrile neutropenia with no etiological diagnosis, either to receive empiric antibiotics that were stopped at 72 hours of epirexia, or they were continued until the absolute neutrophil count was greater than 500. And there was no difference between the arms, suggesting that in high-risk patients with hematological malignancies and febrile neutropenia, empiric antibiotics can be safely discontinued after 72 hours of epirexia and clinical recovery, irrespective of their neutrophil count. So what is the low-hanging fruit? Well, the most easily achievable target that provides significant benefits with fewer resources. What has worked for us since day one when we started was the IV to PO conversion. And it has everything to do with the didactics and case presentations, because every month I learn exceptionally new information that are useful to my practice and that have been increasing my knowledge and my confidence in early transition. For example, I've learned some pearls in regards to Staph aureus infections that I have applied in my clinical practice, such as oral cephalosporin use in bone and joint infections, and early transition to oral linezolid after blood cultures were negative, and source control has been successfully achieved using CRP as a surrogate to discontinue antibiotics at 4 weeks. We've implemented standard operation procedures and infusion order forms for antibiotics as the backbone of medication administration in the future outpatient infusion room, because we want to have in-house an OPAT service as well. Learning about OPAT and being committed to building a program in-house is something that makes me think that I am lucky, finding something that you consider great work, and bringing another passionate people around you is something really beautiful. Stewardship has worked very well for us because I have a portfolio of 22 interventions that focuses on discharge and transition of care. I actually think that discharge is a great time to reconsider and rethink about things. And we've engaged with nurses, lab people, pharmacists, and physicians from 11 hospitals discussing ways to measure appropriateness of antibiotic use, ordering test levels for PK monitoring, de-escalation strategies um, for example, or even discussing with the lab people, because as a microbiology nerd that I am, we were discussing ways to write together algorithms of clinical pathways for empiric therapy based on the mechanisms of resistance on the antibiograms and susceptibility data. And something that I've wanted so bad for so long, the therapeutic drug monitoring for linezolid. And the reason for this are actually two. First, it has to do with its pharmacokinetics and having a huge variability in exposure. And on the other hand, patients in the oncology service already have low platelets. And in my clinical practice, when we are discussing during rounds the IV to PO switch from vancomycin or teicoplanin to linezolid, usually teicoplanin because it's our agent of choice for MRSA infections here in Europe. The phrase that pops out frequently is using linezolid in oncology patients with a platelet count below 50,000 is risky, as it is a known risk factor for worsening thrombocytopenia and bleeding. But this is because the most common adverse effects are those and duration dependent that people would take most seriously, such as thrombocytopenia and anemia. And I was looking up at the incidence of thrombocytopenia and anemia because I know within our oncology department, I haven't really seen that many thrombocytopenias related to linezolid use. But here in my practice, this is something that everyone's always afraid of, and they kind of get afraid to use linezolid for more than 2 weeks. And thrombocytopenia is reversible typically. So when you stop the antibiotic after a few days or so, about a week, it will resolve and the counts will come back up again. I couldn't find the study, but the CID had a publication last year about linezolid use in the oncology service, where patients already had low platelets, and they followed patients with platelets below 50,000 that were starting linezolid, and they found that over time their platelets went up as their oncological conditions responded to chemo. My priorities, which are priorities for me, for our hospital and our leadership, is training, because I am responsible with the implementation of the program in the hospital's structure, and it would fill the biggest pieces of the puzzle that are missing. For example, we are not having an electronic medical record, and together with the IT department, we want to implement our integrated electronic medical record, where everything is done with some clicks rather than a pen and a paper. And from a stewardship point of view, I want to make the right thing easy and the wrong thing hard. Talking about testing, choosing the antibiotic dose, duration, having easy accessible guidelines, and so on and so forth. And very important to measure the appropriateness of use based on days of therapy and not DDDs like we are doing right now. Another priority for me is taking the board certification exam in infectious disease in 2028 when I will meet the eligibility criteria, because I bought the BCIDP material last year when we started the Stewardship OPAD and COPAD lecture series. And the monthly antimicrobial echo sessions combined with the BCIDP path that I've been committing to since 2024 have made me realize that building a lifelong career around stewardship is my ultimate career goal. The Society of Infectious Disease Pharmacists Stewardship Certificate, having the practical project around OPAT with presenting the data as a poster presentation at the ID Week conference, and helping others to implement a stewardship infrastructure to combat antimicrobial resistance in our country using our data, experiences, and mistakes, because mistakes and failures are mandatory for success. And I want to continue giving everything back to the community and the patients. And as an ID pharmacist, this is the quote I will put on a T-shirt because I truly believe in it. If you hang around with 5 antimicrobial stewards, you will become the 6th. Oh, in the end, I want to say thank you to all of you. I mean, Chantry, Kelly, Jay Mason, Dr. Sori, Dr. Johnson, Dr. Joskovic, all the amazing Project ECHO members, the incredible ID pharmacist from your organization, and Dr. Stevens for sharing the initial announcement of the series. I am so thankful to be here and humbled to be a part of this amazing group. It's been wonderful. All of you have a special place in my heart, and for all of the reasons mentioned earlier, I am forever grateful. And the image from the right is the hospital I work in, where the magic happens related to stewardship. Yeah, thank you.